To the best of my knowledge, Australia has a very high and increasing life expectancy. I think we're around about the second highest in the world compared to Japan. And Japan is unique because of various lifestyle factors. I think that supports what John has said, which is that doctors and the health system in general seems to be doing a pretty good job of keeping people alive, at least. And then the questions John poses about what that means in terms of quality of life at the end of life are ones that we're just simply not prepared to address it at this point. So I think it's really valuable that John has raised that. The issue for Helen, a lot of the preventative health stuff to me seems to be an example of middle-class fascination with their own lifestyle, combined with a second phenomenon, which is, I think, a sort of displaced religious ethic in a secular age where some people are determined to try and save the proles from themselves or from what people consider secular sins. And I think this was interesting, but it doesn't actually work politically. I think one of the arguments about the decline of Kevin Rudd's popularity was that he got on the skids when he started, his government at least, moved on drink, gambling and smoking. Take it away, and I'll ask people to raise their hand if they'd like to ask a question. Do you have any comments?
Well, when I was a young doctor, we had so many people who smoked, ate Vincent's APC or Beck's powders every day of their life, and they certainly came to sticky ends that were fairly swift sticky ends, because there was no such thing as coronary artery bypass, certainly no concept of stents, which are a much more modern thing. And people frequently died of heart attacks at the age of 55 or 60. That's almost unheard of today. There are rare exceptions. Everyone knows of some poor person who did die, and apparently young, often an ex-sportsman. But it's really unusual for people today to die of heart attacks. There have been other changes where prevention's been good. There's a lot of criticism against doctors for treating people with antibiotics for what appear to be simple infections. I disagree with the concerns there. If you look at an awful condition called rheumatic fever and its impact on heart valves and then the either death or major surgery being required, that has almost disappeared from this country purely because doctors have given people penicillin or amoxil or their favourite antibiotic when they turn up and say, look, I've got a really sore throat, I wish someone would do something for me, and they do it. This is particularly something where maybe the Aboriginal population haven't quite had the luck to see doctors as easily, and if you want to find rheumatic fever still in Australia, you've more or less got to look at the Indigenous population, because you won't find any in Paddington or Ryde or Campbelltown. There are no cases anymore. Peptic ulcer. Doctors can't even find patients now with a peptic ulcer to run a trial of any new drug, because everyone can just pop along to the local chemist and say, over the counter, can I have some Losec or Somac or Pariet or Nexium or one of these proton pump inhibitor drugs, and they don't ever get an ulcer. So that's a good prevention too. Quite expensive, I guess. Someone's picking up the tab, and it's either us through buying them over the counter or the government putting a bit of a subsidy in behind it. But so there have been changes that have occurred, but what I'm really wanting to get you to get your minds around is if all these good things keep happening and it only then shifts us by virtue of longevity into a category of looking at these awful outcomes, especially dementia, and ending up in nursing homes, or they don't call them that anymore, they call them aged care facilities because that's politically correct. And some of them don't appear to have nurses in them anymore, at least in the middle of the night, so I guess they can't be called nursing homes. If that's where you want to end up, well, urge your doctors to keep you alive longer and longer, because at the moment there are no cures that look as though they're going to stop, especially macular degeneration and dementia.
Okay, question?
Yeah, I wanted. Thank you. My name is David Sinnott. I wanted to make a comment to Dr. John Graham and ask Helen a question. Just that I thought your talk was one of the best talks in favour of euthanasia I've heard, and thank you for it.
Are you volunteering?
Oh, I also have 2 stents, so I thank my health fund for that. But my question to you is really about this question of prevention. One of the conclusions which comes from the litany of failures you've talked about is that all these prevention programs started off too late. And I'll suggest the prevention programs for almost any of these issues should probably start at primary school, if need be a bit later at secondary school, and two education systems, particularly the one in South Australia, has for some time now been trying to inculcate good health practices in schools. Now, what this leads to, you're saying to the current generations, you live by your own sins. But our prevention programs are directed at the forthcoming generations, and that's where we're going to save our money. That's where we're going to get improved qualities of life. And next time you're doing your research, which is not a criticism, could you have a look at that? What would have happened had this person much earlier in their life started on an appropriately managed prevention program? And thank you for the opportunity.
Everything that you've just said, I have heard come out of the mouth of Jamie Oliver, which does not... Jamie Oliver, the British celebrity chef, which does not necessarily mean that it's wrong. Jamie Oliver has done several pilot programs with young school children on the logic that you have to get people early and train them into the right habits. And I guess we'll see how that works. I mean, the school children programs, getting them to eat more vegetables by literally giving vegetables away, hasn't seemed to work. So I don't know about the Jamie Oliver programs. On the other hand, if you want to bring back home ec and teach kids, you know, how to cook, I wouldn't have a problem with that.
Can I respond to the comment? Because I'm not in favour of euthanasia. I think killing anyone is not a good thing to do. And for heaven's sakes, I think the Australian people, in their attitude to what's happening in Indonesia at the moment, I think I'd have 99.9% of people on my side in saying that killing people is not a good thing. And I don't think doctors should kill people. That doesn't mean that you should keep people unnecessarily alive for a lot longer than nature would otherwise dictate. People say, well, it's all very well to talk like you're talking in that global sense, but do you have an answer? And that's where, sadly, I have to say, well, I don't. And if I go back to being a doctor, then every patient is a one-on-one association. And for that person, and I think I'd be speaking on behalf of the vast majority of doctors, that relationship is one where you lay all the cards on the table about, I'm about to treat you with something because these look to be the benefits, these are the downsides, are you happy that I go ahead with that treatment? And you talk through the implications of managing something one way, not even treating it at all, managing it another way. And if you do that, at least you've been honest and honourable with every single patient you look after. That's very different from what the government is going to be faced with when they look at a whole nation and have to say 14.7% of people over the age of 70, if they go the same as the United States, are going to be demented and costing a lot of money for their care. If I were running Australia, I'd get rid of every health bureaucrat and I'd spend every one of those dollars on research, and I'd try and work out how to stop amyloid being laid down in the brain of people with Alzheimer's. And I'm sure it will be done, but it's going to take a lot of effort, and people should be focusing on the real things in healthcare instead of focusing on pie charts and graphs and monitoring policies and protocols and stuff. That's nonsense.
We could have an interesting debate.
Hello. My name is Kathleen Henrihan, and you've almost eliminated my question. I'll say that I was going to say straight out, I don't believe in euthanasia either, because I wouldn't trust the system if they brought that in, because they might give it, decide to give away, kill Catholic old ladies who have turned 71. And that'd be me. But anyway, I've worked in aged care. It was a nursing home when I worked there for 20 years. But my experience with living with dementia people is I've always said I would like to see the system where you're demented, your life's finished, you're finished. It's the last bus stop. Time to give your heart pill up, your kidney pills, all the pills, throw them out, just give them painkillers. Can't let people suffer. Painkillers, nourish them, care for them until they die in peace. Do you? And I think you do agree.
Look, your thesis is a good one, and essentially I'm on the same ticket that you're on. Same applies when you're treating people who are dying of malignant disease where they have no hope. You have to reach a point where you say, this is ridiculous, giving you more oncological drugs which are only going to make you vomit and make you get even worse peripheral neuropathy and make your hair fall out even worse than it ever has and so on, when you should be just being compassionate and look after that person the way you'd hope someone would look after you. And that's not the push for a maximum life.
And if I may draw on my religious studies background, I know that in the media, the Catholic Church is very often depicted as a bunch of fanatics, the people who wouldn't let you pull the plug on Terry Schiavo. But there's nothing that Dr. Graham has said that the Catholic Church wouldn't be perfectly happy to endorse.
Good evening. Tim James is my name. Thanks very much, Helen, Dr. and Jeremy. I should say I'm a personal member of the CIS. Professionally, I'll declare my interest. I'm the Chief Executive of Medicines Australia. We're the peak body representing pharmaceutical companies in this market. My question is, how can we get public policy makers in Canberra, in particular, to apply health economics, health technology assessment, notions of value and cost effectiveness across the health system and right across certainly the Commonwealth health budget? And part of the reason, of course, I ask that is because that's what we must do in order for any new medicine to come to market. It has to be proven to be clinically effective and cost effective. If we don't make it through the most rigorous process, that medicine will never get to the Australian people. So I'd love to get your thoughts on, and I think it's very relevant in the context of hundreds of millions of dollars being spent on prevention and indeed in a range of other health measures. I'd love to get your thoughts on how we can drive value, bang for taxpayers' buck in our health care system. Thank you.
Well, the most important thing is that you have a process that's not politicized. There's a nonpartisan board that governs prevention treatments and which ones are covered by insurance and not in the United States. They've got a preventive health board. And there's almost a sort of case study in two different ways to approach the problem that you've described, politicized and not politicized. The Preventive Health Board in 1998 decided the science doesn't back up mammography screening for women between 40 and 50. We shouldn't cover it, only if you're older than 50. The Senate voted 99-0 not to endorse that particular judgment because they didn't want to be seen as against mammograms or pro-cancer. Then in 2009, exactly the same thing happened. The board said the science isn't there for the 40s and 50s, and there was some hesitation, but eventually the Obama administration and Secretary Sebelius backed them up. So I think that's a change for the better, and it applies equally to Australia, that you can't let the process get politicized, because if you're dealing with matters of life and death, it's got to be independent, otherwise you're going to get a non-scientific result.
I've had dealings with state and federal health ministers now for 30 years, mostly over matters of common sense public health policy and national security. But I've come to the realisation that if you either need to talk to the Minister for Health without the Director of Health present, or you need to talk to either the Prime Minister or, if it's a state thing, the Premier. Because anything less than that, you find that there are so many balks and impediments and people wondering, oh dear, behind the scenes in the bureaucracy, that you won't get anywhere. And you need a really good lobbyist who's really personable and who's able to carry an intelligent argument directly to the Minister or even the Prime Minister or Premier. Otherwise, you just have to wait until the various professors of medicine or whatever have had their PhD students running trials of your new drugs and another clinical trial, and you get a big bag of clinical trials and you count them down and say, look at this, all these doctors can't be wrong. And finally, they start to put things to the PBAC. And
I would just like to make a couple points about that. One of the barriers to doing the sort of evaluation that you're talking about is actually that it's politically easier just to talk about prevention. Everybody likes to, particularly if you're a politician, you're doing something positive for people. You're not talking about not spending money. Secondly, talking about prevention is a good way to avoid exactly the issues that John has been talking about, which are the obviously sensitive end of life care issues. The issue that John's talked about, that spending money on health doesn't necessarily improve quality of life. That won't be an issue that any politician will be prepared to start until there's a community debate about it. Where that community debate should naturally come from, you would think, would be among health professionals, among doctors. Off the record, doctors will say similar things to what John is saying. They'll also tell you about, disgraceful episodes of over-servicing, asking questions, why are we replacing the knee of a 90-year-old demented man? I've heard those sorts of stories. But the collegiate professional ethics of the medical profession means that, again, they seem to be unwilling to speak out publicly about these issues, so it's hard to generate the debate. That, and I think the bureaucratic combined with the political issues that I've talked about as well are an important barrier. That leaves the question of whether you'll ever get to that point with a top-down process, or whether, and this is something that I'm interested in, is exploring ways to actually give people more control over their health dollars, and that it'll have to be a bottom-up process, because that's really where innovation and changes to what in a lot of cases are vested interests come from. So I think, it's not like there isn't enough medical professional bodies that couldn't start this debate, but they're not prepared to actually start it.
Yes, thank you. Michael Potter. Wanted to ask for you to comment, the panelists to comment on issues about rhetoric. We were hearing earlier about the case in the US where people were, the Senate voted against some legislation which would have stopped a preventative health measure because if you did that, you appear to be pro-cancer. So I'm just wondering, is there an issue with rhetoric around this, that if you are raising questions about a preventative health measure, then you seem to be pro-cancer or pro-heart attacks or pro-obesity? Is there a change in language which would be appropriate for people to use? Thank you.
How many people in this room watched Q&A last night? Oh, about half. Malcolm Turnbull had the answer to your question, because he basically said, if you want to do something that's sensible and take people with you on the journey, you need to be simple in your message, explain exactly what you're up to, and don't use slogans, don't downgrade the intellect of the people you're talking to. They're sensible. And I think if people are prepared to spell out the message, it's not so hard to sell it, provided you are clear, honest, honourable, and sell the message by repeatedly talking to the whole community. Now, as Jeremy said, the medical profession are not going to come out and appear on Q&A and talk like I've been prepared to talk with you here today. And you can understand why they won't. I can tell you for certain, if you are still in practice, and especially if you're a consultant, you've probably got hospital appointments, you will be given an absolute caning behind the scenes by the bureaucracy. In doing a lot of talking out that I've done over the last 15 or 20 years, I can tell you there have been people who've said, John, you are so brave. And fortunately, I got myself into a position where I didn't care what they said to me or said about me. That didn't worry me at all. So you become a bit impregnable then, and they didn't like it. The bureaucrats hate it if there are people who are prepared to talk openly, honestly, honourably, and with some common sense, and it doesn't happen to tally with what they'd like you to be talking about. Now, I haven't answered your question as nicely as you'd like, I'm sure, but I do think if you are open and honest and you explain the things and you put the facts on the table for people, they're prepared to look at things and different ways of going about solving.
And that's exactly what happened in the 1998 versus 2009 mammography question. The science hadn't really changed or developed all that much. It's just that in the latter instance, the people who were arguing for a science-based policy were willing to go on cable television and put up with 15 seconds of being called pro-cancer and then make their case. And it was a little complicated, and I'm sure that there was some PR person in their office saying the people will never understand it. But in the end, they did. If you look at the polling now, it's actually pretty much in favor of the Preventive Health Board, saying they say they're not going to cover it for 40s and 50s. We understand why there are more risks than benefits. Good enough for me. Average people.
Norman Swan, a sort of challenge for John and a question for Helen. My understanding of the data is different from yours, John. My understanding of the data is that the causes of an increased life expectancy are also the causes of an increased healthy life expectancy. So people are getting heart disease later, and there's even evidence now that dementia rates are tailing off from the Scandinavian countries where the data are good. So the cause of a healthy, if you have a healthy lifestyle, what's good for your heart is good for your brain. And also increased education levels. Dementia is occurring late. So the dementia epidemic is not actually going to happen to the same extent. And Denmark is seeing a tailing off of that. So I'm not sure where you're getting your data. It doesn't look as if the extra years are spent in extra misery. They're actually spent in quite good health. At cost, but good health. And my, just hold that thought, and my question for Helen is, it comes to, I think, David's point earlier, which is the evidence on drugs, alcohol, and obesity is, well, for obesity is, Joe Peretta's work at Monash shows that childhood obesity is the key, is the thing you've got to tackle, because your appetite hormones are set by your late teens. So, and that's a group that's at its most price sensitive, and it's the same for drug and alcohol. So if you increase the price of cigarettes, it doesn't affect the average. If you look at the global average on cigarettes, it doesn't change it much, but it changes it a lot in teenagers when they're taking it up, which is why the tobacco industry fights price hugely, and why the alcohol industry is fighting price hugely on price there. Because the overall effect is tiny, but huge in the target group. So why resist price signals to the most price-sensitive group?
Norman, can I answer your question to me? And I acknowledge that you would have at your fingertips far better statistics around the world on these sorts of things than I do. I remind you, I am retired 4 years now, and so I've not been concentrating quite as heavily on where things are as I might have had I still been in practice. But I will say that when I was a young doctor, so I'm going back 45 years roughly, I hardly saw a patient with dementia other than the chronic alcoholics, who were numerous in the hospital that I was trained at, and they certainly became demented, and when we finally got things called cerebral scans, radioisotope cerebral scans, which were the first new thing after just doing a skull x-ray, we were aware already that they had considerable cerebral atrophy, and they certainly got demented, but the patients were, best of my recollection, they were dying in their 50s and 60s and early 70s. Anyone who got the 70, we thought they've done all right. Now today, I can only base what I say on the last few years of my career, which certainly saw an awful lot of patients who had managed to live a long time, some, I hope, because of what I'd done for them over the years, becoming demented and ending up in nursing homes. And as I announced earlier, that New England Journal of Medicine article from 2013, and 14.7% of all Americans over the age of 70 being demented in the year 2010 and causing huge health costs. You know, they're the personal vibes I have, and some figures from a really worthy article. I think dementia is a real problem, and I don't see it slowing down at all in this country.
Okay, so you asked about the proven importance of reaching people when they're young, and the fact that young people are particularly sensitive to price signals. You're absolutely right that appetite hormones are set when you're young, and also habits are set when you're young. And you will be pleased to hear that in New South Wales, at least, childhood obesity is declining. Overall obesity rates tend to still be trending up, but childhood obesity in Britain as well has also shown a dip. So people are getting the message, I guess. It's true that young people do make more decisions based on tiny fluctuations in price, but cigarette taxes, in addition to disproportionately affecting teenagers, also disproportionately affect the poor. All of these sin taxes are terribly regressive. So I think just from, well, I hate to use the phrase social justice, but from a general fairness perspective, I think there's that strike against them to compensate for the sensitivity of teenagers to these things. And also, the taxes, the sin taxes that most people are proposing nowadays are not on tobacco, but they've moved on and they're talking about soda taxes and fat taxes. And those are a completely different animal, because if you're trying to tackle obesity, it's not like smoking where you've got one small target, to stop people smoking cigarettes and you've taken care of your problem. With obesity, there's no one food, one thing you can tax that's going to get rid of the problem as simply as it did with tobacco. So for all of those reasons, I think the taxes are still pretty dubious.
Jeff Hogben, this is probably not a bit off the track. We'll take you somewhere else. I'm a bit puzzled. These two things that affected me. One is that the anti-smoking campaign was sold almost entirely on the risk of lung cancer, which is not all that high. I think it's 1 in 10 or something like that. You know, it's significant, but not all that high. But what's almost certain is that you will get receding gums. It will affect your eyes badly because of the circulation, the problems with circulation that smoking causes. And these seem to be far more. Had the anti-smoking campaign been sold on those issues as well as lung cancer, then I think I might have changed my attitude towards smoking a bit. If I knew for sure that I was going to get receding gums and so on, that would have made a difference to me. And the other one that's a bit similar and also impacts me is that when I was young, I used to get indigestion a lot, and so I'd whip over to the shop and buy a packet of Quickies and swallow them. Nobody ever told me that acid reflux can cause permanent damage to your alimentary canal, and that was very likely to happen. And now I discover there are all sorts of people who've got this problem too. And I wonder why these weren't part of the campaign, you know, why the medical profession doesn't provide this sort of information, which I think is terribly valuable.
Well, you will be happy to know that the anti-smoking campaign has discovered exactly the same revelation that you have. They found that, especially for women in their 20s, it doesn't make all that much difference to their smoking rates if you tell them this will give you lung cancer and make you die. It does make a difference if you tell them it's bad for your face. And so now they're running campaigns on those grounds, so yeah.
But I do think the medical profession has done a good job of telling people not only about the problems of why you should stop smoking, where in fact causing heart disease, coronary artery disease, is a far bigger problem in smokers than lung cancer. It's just that in today's technological world, you can pretty much stent nearly anyone who's got coronary artery disease, and so, you know, it makes them feel, well, that one wasn't a real worry because, you know, 3 or 4 hours in someone's cardiac lab and I'm better again. Got another 10 or 20 years to go, right? So you can get a recharge of the battery. But in relation, say, to your acid problem and your peptic problem in your stomach or your esophagus or wherever it happened to be, when I was a medical student, the only treatment available for anyone like that was to bed rest you and put you on a milk drip. That was all that was available. There was nothing else. Then some drugs called anticholinergics came along, and they were nigh on useless and did very little more than give you a dry mouth and a placebo effect. Then, however, along came a group of drugs called histamine 2 receptor blockers, of which Tagamet and Zantac would be the two that would probably be the best known by this audience. And I remember a visiting famous surgeon from Birmingham, J. Alexander Williams, arrived at Sydney Hospital to be the guest speaker for the hospital week. And he was going to give his main talk on the new surgery for peptic ulcer called a highly selective vagotomy that he'd developed over in the UK. And on the same bill they put me on. I was at the time the senior medical registrar of Sydney Hospital, and I was going to tell people about this new tablet, Tagamet. And it totally meant that the surgeons were sidelined. There is virtually no surgery has to be done anymore, whatever, for peptic ulcer in a country that has a free supply of Zantac and Tagamet. But even better, since then, the proton pump inhibitor drugs, which are Losec and Somac and Pariet and Nexium and so on, they absolutely got rid of peptic ulcer. And if you want to ask me about Helicobacter pylori, I don't think it's a cause of peptic ulcer at all.
You didn't get a Nobel Prize.
I didn't.
Thanks. Mitch Frost, don't you think a lot of the problems, the basis of this, is that doctors tend to like to criticise other doctors? I have a number of friends in research, and it doesn't matter how much evidence they've got, how much research they've got, other doctors criticise them because they don't want to seem to get one step up on their colleagues.
I don't know that the criticism angle is there, but competition is very keen. And surely in any walk of life, if you take intelligent people, whether they're QCs at the bar, whether they're the best architects in town, whatever, the competition is intense because everyone wants to hopefully be the best, right? And so I don't think there's a problem with competition, and I don't see that as being a situation where you criticise. You compete, but not criticise.
Sorry, quick one.
I remember talking to a health industry actuary who said it isn't because people are getting older that health costs go up, it's because the greatest amount of health costs in a person's lifetime is in the year before death. And therefore, since people are getting older, therefore it's going to look like older people cost more health, but it's really because they're near that. And David Williamson co-authored a play about 4 years ago, which title should have been "We Do Because We Can," showing all the costs the medical profession can incur, because it must be very hard for a doctor to say to not to the patient, but to the patient's family, we could do this, and they do. And well, huge costs. Would you like to comment on that?
I'd love to. Norman Swan might be able to comment even better, but certainly when I was a young doctor, we were taught that 50% of all the lifetime costs in health were spent in your last 6 months of life. Now, and if you averaged out the community at the time I was being told that, where a huge number of people dropped dead of heart attacks, which doesn't happen today in people's 60s and so on like it used to. I think things have probably changed, and I bet it's more than 50% of lifetime health expenditure occurs in the last 6 months of people's life today, because the vast majority of people today do not die suddenly, which at least half of them did only a generation ago.
There's a lot of...
But Norman might have some better statistics on that. What Norman said is right. There was a study done of general practitioners in the UK about 30 odd years ago, and I think there were about 500 GPs were in the survey. It was at a time where still at least half of them smoked. And one of the questions was, if you smoke, do you intend to still keep smoking? And the staggering surprise answer was yes. And when that was then nailed down, well, why on earth, if you know what the risks are, they said because it absolutely increases our chance of dying a sudden death, which is what we all want.
Thank you. Over the years, the CIS has done a fair bit of work about what we've come to call the nanny state. And one of the points we've always made is that there is an appropriate role for public education to inform people about what positive choices they should make to maintain their own health. Where it gets complicated is that human nature is often different and people respond to messages in different ways. And that's when we get into the complicated area of what we call the nanny state, where governments try to micromanage and people's behaviours in ways that are often ineffective, as we've heard tonight. And what we've also heard tonight is that even when we manage to get success, there are consequences that we may not have anticipated, both personal and public consequences in terms of cost and quality of life as well. Tonight's gone in a different direction to what I anticipated, and I think that's a tribute to the speakers and their contribution. Thank you for attending. I hope we'll see you back here again soon, and if you could thank our speakers, that would be great.